Hello class, and welcome to Lecture 3. In this lecture we will be covering the diagnostic criteria for PKU as well as pharmacological therapy and medical interventions used for this condition. In 1962, Dr. Robert Guthrie developed a diagnostic test for PKU. The Guthrie test is a bacterial inhibition assay. It uses a strain of Bacillus subtilis that requires phenylalanine for growth. Growth on the agar plate indicates excessive Phe, or phenylalanine, in the blood sample. Before this test, a ferric chloride urine test was used. This tested for the presence of phenols in the urine. Specifically, it screened for phenylpyruvate presence in the urine, which is a derivative of phenylalanine. This was indicative that the individual had failed to digest phenylalanine properly. This test had limitations, though, and it could not screen for Phe levels below 20 milligrams per deciliter. This inaccuracy led to many patients with PKU going undiagnosed. The development of the Guthrie test led to more accurate screening results, and it is what we still use today for newborn screening. PKU is the first disorder to be regularly screened for in newborns due to the devastating consequences if not treated early on. So what is newborn screening? Newborn screening is completed at the hospital shortly after birth. It is often completed within the first 24 to 48 hours of life. The 24 to 48 hour time frame allows the infant time to ingest protein so the test can produce an accurate reading. In the state of Alabama, a second screening test is done 2 to 6 weeks after birth, just in case the first test was a false negative. Every state is allowed to set the standards for what diseases or conditions they may screen for. In Alabama, 45 different conditions are screened for in the newborn screening tests. However, PKU is federally mandated to be screened for in all 50 states. These tests are necessary to screen for diseases or conditions that could have severe lifelong impacts or even early death. They could be developmental, genetic, or metabolic conditions. It is important to remember that newborn screening is not a diagnostic test. It is simply identifying abnormal values in newborns that may indicate having a certain condition. Further testing will be done if an abnormal reading occurs. These additional tests will be what confirms the actual diagnosis. It is also important to note that newborn screening should not be referred to as the PKU test, as it screens for many other conditions, not just PKU. So an abnormal result from newborn screening does not automatically mean a diagnosis of PKU. A heel prick is the most common way to conduct a newborn screening test. This involves making a small puncture in the newborn's heel and collecting a few droplets of blood. These blood droplets are placed on a special paper absorbent card and sent to a laboratory for testing. This can actually be somewhat difficult to perform because the blood droplets must be precisely placed on the card and several dried blood spots must be made. If an abnormal result occurs, further testing will be warranted to confirm a diagnosis of PKU. When testing for PKU, abnormally high levels of Phe and abnormally low levels of tyrosine are indicative of PKU. The Phe-tyrosine ratio is also evaluated. Because it is federally mandated to screen for PKU in all the U.S., it is very rare that newborn screening will miss a PKU diagnosis. However, there are some instances where a false or inaccurate reading may occur. If an infant is born prematurely, this could give a false positive reading due to certain liver enzymes not being developed yet. Feeding problems can also give an inaccurate reading. If the infant does not feed well or has problems with vomiting, it could give a false negative reading because not enough protein has been able to enter the system of the infant. If the initial blood sample collected is too small, a false positive result could occur. And if a test is conducted too early, this could result in a false positive reading as well. If results come back with blood phenylalanine levels of 4 milligrams per deciliter or higher, this could indicate PKU. In non-PKU individuals, blood Phe levels are typically 50 to 110 millimole per liters or less than 2 milligrams per deciliter. An altered ratio of phenylalanine to tyrosine in the untreated state with normal BH4 or tetrahydroopterin cofactor is also evaluated. If the Phe-tyrosine ratio is greater than 3:1, this indicates PKU. Genetic testing may also be done to confirm genetic mutation of the PAH gene. However, this is not done too often because the treatment really doesn't vary depending on the type of genetic mutation of this gene, so it's not really necessary to do. If PKU has been determined from other serum tests, then it is assumed that they would have a genetic mutation of the gene. If molecular genetic testing is done, though, the test would screen for biallelic pathogenic variants of PAH. The most common and severe form of PKU is known as classic PKU. It involves the complete or almost complete absence of phenylalanine hydroxylase, which is the affected enzyme. PKU patients with this type will exhibit the most severe symptoms, and they are the most sensitive to Phe levels in the blood. Variant PKU is an intermediate form of PKU. Patients with this type of PKU typically have blood phenylalanine concentrations of 900 to 1200 millimole per liter. Symptoms in this form of PKU are often milder than the classic PKU. Dietary restrictions will still be necessary in these patients, though. The mildest form of PKU is non-PKU hyperphenylalanemia. It is also known as benign hyperphenylalanemia or mild hyperphenylalanemia. These patients may experience mild or no symptoms of PKU. Patients with blood phenylalanine concentrations of 600 to 900 millimoles per liter are considered to have mild PKU. These individuals have higher levels of PAH enzyme than individuals with classic or variant PKU. So some of them may have low enough Phe levels that they do not need to consume special medical formulas or follow a Phe-restricted diet. Kuvan is a synthetic version of the natural cofactor tetrahydrobiopterin or BH4. It is the cofactor for the enzyme phenylalanine hydroxylase. The mechanism of action is to stimulate the metabolic activity of PAH that may still be present in the patient's body. Kuvan was FDA approved in 2007, and it is currently the only medication FDA approved to treat PKU. It is not approved in the U.S. for children under 4 years of age. Kuvan is used as an adjunct therapy to dietary restriction of Phe, so it is still necessary to follow the dietary restrictions for PKU, even with using this medication. It is not a cure for PKU, and it is not used again as a standalone treatment. Kuvan is not effective in every PKU patient, so to be certain of its efficacy in patients, doctors would have to do a trial run of the drug to see if it would work. The most common side effects of Kuvan include headache, runny nose and nasal congestion, sore throat, diarrhea, vomiting, and cough. Pegveliase, also known as PegPal, is an investigational study drug that substitutes the deficient phenylalanine hydroxylase enzyme with a pegylated version of the enzyme phenylalanine ammonia lyase to break down Phe. This drug is being developed as a potential treatment for adults whose blood Phe levels are not adequately controlled or for those who have trouble maintaining goal Phe levels. It's a subcutaneous injection, and this drug is currently not FDA approved, but is undergoing phase 3 clinical trials, which means that they are trying to demonstrate that this new drug is more effective and or safer than the current standard treatment. Once the clinical trials are completed, they can submit a new drug application to the FDA for approval. So far, the results have shown that the treatment effect of PegPal demonstrates about a 62% improvement in blood Phe levels compared to placebo groups. This drug is being developed by the same company that developed Kuvan. Age-specific neuropsychiatric and cognitive testing is necessary to adequately assess clinical needs of PKU patients. Appropriate intellectual and mental health assessments are an important component of care for individuals with PKU, since they are at higher risk for neurocognitive and psychological issues. It's important for individuals with PKU to regularly monitor their serum Phe levels. The maintenance range for serum Phe is 120 to 360 millimoles per liter. So an infant's serum levels are checked by the heel stick, but once the child is older, blood samples will be taken by finger prick. And this is important to do regularly, so this will have to be done on a consistent basis. When checking the Phe levels, it is important that they are done consistently, so they should be done at the same time of day and should not be done before eating. Persons with PKU must include special medical formulas in their diet along with the low Phe restrictions. This is so they can still get necessary nutrients that they cannot get from foods. There are special infant formulas available, and once they get older, there are formulas for children and adults. These formulas can be pretty costly as they are not always covered by insurance. Though they are considered medical foods, they are not considered a drug, so insurance companies will not always cover the cost. However, they are still necessary for individuals with PKU, so these families must continue to buy them. It's not an option. It is important to assess and consider economic status of patients and their families when working with them on dietary management. There are a lot of different brands of formula available, and they have varying costs, so you'll need to work with them to determine which formula best fits their budget and lifestyle. So going back to our case study patient Sadie, review and answer these two questions to check your understanding of the material. So question 1. What kept Sadie from displaying symptoms discussed in Lecture 2 earlier in her life? And question 2, would Kuvan be an appropriate treatment option for Sadie? Why or why not? This concludes Lecture 3 material.